As we all know, guided surgery is all about the fundamentals of treatment planning and is dependent upon an accurate surgical plan. An accurate surgical plan is dependent on visualization of future tooth position. The drill guide will deliver a hole where you aim it. The challenge is to create a surgical plan which aims the guide correctly. To meet this challenge, virtual planning software must include the necessary data for visualization of future tooth position. We at Guided Surgery Solutions have attempted to streamline the virtual planning process by incorporating scans of readily available models into the Blue Sky Plan planning software. Before we start, I would like to present an overview of our patent-pending guided surgery system. Our guides, which we call the ThinLayer guide system, include a ThinLayer guide, which is a tubeless guide, plus a ThinLayer tube guide, which functions like a conventional tube guide, in addition to custom disposable drill stops for depth control. This is what we provide for every guided surgery case. The tube guide is used as conventional tube guides are used. However, because of its streamlined form, you can actually reflect the flap and easily see the surgical site when you're using the tube guide. Our ThinLayer guide is made for special circumstances where you have issues with vertical clearance, since it requires no more vertical clearance than freehand drilling. Our system is versatile. The guides offer retention and a stable fit. They're usable in posterior areas, even second molars. You have access to the surgical site for flap reflection, if you wish, and they provide depth control. The system is a practical one. It uses free implant planning software, the Blue Sky Plan software. It can be used with most standard implant drills and can be used with all implant systems. In summary, it's a versatile, simple, cost-effective guided surgery solution. The steps to guided surgery may be familiar to some of you, but I'll review it. A patient cone beam scan, a stone model, a model or models indicating future tooth position, and this is what we'll discuss tonight, merging of the data into the Blue Sky Plan software, and then executing a proper surgical plan, and finally manufacture of the ThinLayer guides. The first case I'd like to discuss tonight is a straightforward case, missing teeth number 29 and 30. And basically, the approach we've taken, we want to make this streamlined. We want to make surgery, guided surgery, feasible, simple, minimum effort. And one of the things I think we have done to a large extent is eliminate the need for barium sulfate-coated teeth or wax-ups. Not 100%, but to a large degree. And I'll illustrate that with this case. First of all, for those of you not familiar with implant planning software, you get at least these four views. You get the axial view, you get a cross-sectional view, you get the panoramic view, and you get a 3D reconstruction. So to plan a case like this, the first thing I do is I go to the pan, I grab an implant, I place the implant. In this case, what I'm interested in on the pan is the angulation and the relationship between this implant and the first bicuspid root. The next thing I do is we use the abutments as future teeth. So it's restorative-driven, and in this case, it's been decided that this bicuspid, this implant-supported bicuspid, is going to be 7 millimeters mesial to distal. It could be 6, it could be 7.5. You just dial the number in here, and you can make it anything you want. So now, by virtue of this abutment contacting the distal of the first bi, and the fact that the implant is centered in the abutment, the spacing, angulation, and relationship between this implant and the first bicuspid is right on the money. The next thing I like to do is duplicate this implant. Now this next tooth is going to be a molar, and again, restorative-driven. I now declare that molar to be 10 millimeters. Now if I bring this molar in contact or approximate to the second bicuspid implant abutment, the spacing between these two implants will be precise because each implant is centered on the future tooth. If there were a second molar here, the process would be repeated. I would duplicate this, slide it over, and for as many teeth as you have in a row, they will be parallel to each other, and the spacing between them will be right on the money. You don't have to measure the spacing between them. You don't even have to know the spacing between them. It's all based upon the future tooth position. Now the pan is distorted for mesial distal dimension. So basically what I'm getting out of this is an approximation of this position, but I am getting this angulation relationship right here. Sometimes you can have a root that kicks back at an angle, and you want to know that when you're planning your implant. I then might go to the model. Now we've scanned in a model of the arch of interest. And on the model, this is very precise and very accurate. So now I can fine-tune my mesial-distal relationships. When you do implant planning, it's a three-dimensional exercise, but when you plan it one dimension at a time. So right now we're working on mesial-distal. So I can bring this first molar here, second molar here, and I can have an ideal relationship between these implants. Again, what we're trying to do is we're trying to create virtually the same process that one would do on an articulator. Except I think when we do it virtually, I think you have more views and can do it better. Okay, so now we have mesial distal. At this point, I'm going to change the abutment sizes to 1 to use them as center lines. And I'm also going to now bring in a set of articulated models. Now what's nice about the software is that I can then project cross-sections of the articulated models onto the cross-sectional views of the patient's arch. But in the meantime, you still can get a look, as you would if you were using a typodont, to see where the center lines of these implants articulate with the opposing arch. Now these opposing arch these are hand-articulated models, and another point to make is that we're doing this at the correct vertical dimension. Sometimes individuals will have their patients scanned to show the opposing dentition, and so if the opposing dentition is not at the correct vertical dimension, you may be introducing an error in the angulation of the implant. And one problem with scanning patients with the upper arch, as you see here, is that if there's scatter from the upper teeth, sometimes that can distort some of the anatomy on the lower teeth. Okay, so now we go to the cross-sectional views. So what you have here is you have an left side's buccal, you have an outline of the opposing tooth. So now, when I set up my bicuspid angulation, let me bring in the center line. not letting me get the center line in the central panel. What I wanted to illustrate was that this implant can be moved buccolingual. And if you picture the center line of this implant up this way, you can manipulate this implant buccolingual so that you can put the center line of the lower bicuspid directly on the lingual cusp of the upper tooth as it should be in an ideal circumstance. And in this particular case, there's plenty of bone, so it allows me to do that. Number 30, the first molar, you can see what you can do. So I can put this right on the lingual cusp. There's plenty of bone, so there's no reason why not to have an ideal occlusal relationship given the anatomy that we have. One nice thing about the software is that, let's say you have a resorbed mandible, and the best you can do is this in terms of implant placement. The software allows you to rotate the abutment and calculates the angle correction. So that's a 19-degree angle correction. So it's very nice to know that ahead of time. And for myself as a periodontist, working with restorative dentists, you know, it's a nice phone call to make to say, I'm doing this case on Mrs. Jones. However, the bone is resorbed on the buccal, and the best I can do is this, and you're going to need a 19-degree angle correction. Are you okay with that? Is this still an implant case? So it's a very nice bit of information to use collaboratively with the restorative dentist if you don't restore it yourself. So now we have the buccolingual dimension set. Again, you can go back and check again to see what the relationships are. At this point, I switch out and I go to a model of the lower arch. I often will put divots in the model before I scan it as a frame of reference. So this divot's 4 millimeters distal from this bi. This divot's 8.5 millimeters distal from the first, so that I can see exactly where I am on the arch. Sometimes virtually, if you have a large rounded arch, you can place the implant beautifully, but you might find the implant to be off-center clinically when you look at it in this fashion. So I like these divots as a frame of reference. And if, in fact, I'm way off, I can go back to see why I'm way off, and then I can see about correcting it. And then finally, well, I'll get rid of this and bring in the patient scan. With the patient scan, you can control the density threshold. So you can make the bone go away but retain the roots. So what I'm showing here is I'm confirming the relationship between, I don't mean to make you dizzy, between this implant and this root. So now, looking at this, I'm convinced that this is a very nice relationship and the distance is appropriate. So, in essence, now we have a plan. This plan would be saved and then submitted to have a guide made. Michael, are there any questions about the planning process so far?
No, there are no current questions. If anybody has questions, please enter them into the chat box on the bottom right hand of the screen.
Okay. I'm going to now go on to another case, which is similar to that case, but I have a set of surgical slides to go with this case. So this case is done in exactly the same way, where the implants are brought in. There's an implant library with Astra-compatible, Zimmer-compatible, Noble Active-compatible, Straumann, Noble Replace-compatible implants. You can select diameter and you can select length, mandible, maxilla. I brought an implant in. It's the same as I showed you previously. And then again, in terms of spacing, it was done exactly the same way. I lined up, I got my angulation of this implant from the pan and the angulation of this root here. I then used the abutments as virtual teeth. I fine-tuned my mesial distal on the model. Went back to center lines. Brought in the articulated model, projected it onto the cross-sectional views, now here's a good example where I couldn't get it on the lingual cusp. I'm lingual to the lingual cusp because that's the best we could do because of the anatomy of the bone. But at least you know it before you do the case and not afterwards. So now we have the mesial distal, we have the buccolingual. And now I go check with my 3D the relationship between my second bicuspid implant and the first bicuspid. And we have a plan. You also can get density measurements up and down the implant. I find this to be extremely helpful in planning my drill protocol, whether I undersize or not, whether I countersink or not, or how much, et cetera, et cetera. That's very, very helpful information. This software has something called a tangential view, which allows you to swing around the implant 360 degrees and see its relationship to all adjacent structures. It's a very powerful feature. So right now, it's in a panoramic view, as you would get in a periapical film. So I can see the root of the adjacent bicuspid. Now as I swing it obliquely, now I'm in a cross-sectional view. I can see how much buccal bone I have. And now back to a panoramic view. So you can, on any structure, you can place, you can activate, and you can center it in this field, and you can see the relationship between all the adjoining structures. Very, very powerful feature. As you can see, also, we outlined the mental foramen and the inferior alveolar nerve. So basically, all the important anatomical features are known when you go into this surgery.
Let me jump in with some questions that came up regarding the models themselves. One question is if they're CT scanned or optically scanned, and a follow-up question is how you import them into the software.
Okay. we cone beam scan all of the stone models. The advantage to that is that you have no scatter. We use a scan appliance in order to orient the stone model to the patient scan. And so you have to make a scan appliance with fiducial markers on it, and the patient wears that while they're scanned, and then that scan appliance is placed on the stone model, which we or you scan, and the merge is on the basis of those fiducial markers. What's nice about that, an advantage of that over an optical scan, is that we're not depending on any of the anatomical features of either the patient's bone or teeth or gingiva in order to do the merge, so that this technique is absolutely immune to the effects of scatter. When you do an optical merge and you're trying to find an incisal edge or some contour of a cuff tip, several points to triangulate in order to achieve your merge, if there's a significant amount of scatter, there's a risk that the merge is inaccurate, or that some of the companies will clean up your scan for you. And my personal feeling on that is that may not be a very accurate exercise. So because we do it this way, scatter has no relevance to our merges. Was there a second part of that question?
Yeah, do you have a picture of the scan appliance that you're able to bring up? Or can you describe a bit how it's done? Or is it done by you, or could the dentist do it?
It's done by the surgeon or by the surgeon's lab. And basically, it's a suck down using 060 soft vacuum-forming material. You have to block out all the large undercuts. We have pictures of all these things and protocols on our website. And so you make a suck down, but you have to block out all of the large undercuts. The smaller undercuts won't be such an issue. And then we use little 3 millimeter or so pieces of number 50 gutta percha, and you place 3 on a side and 1 in the midline, spaced out relatively evenly on the scan appliance. The key thing here is that the gutta percha has to be placed as deep in the vestibule as possible because of the issue of scatter from any metal in the teeth. So if you get it down in the vestibule, then even if there is scatter, the scatter will be in a different horizontal plane than your fiducial markers. So the scatter will not obliterate the fiducial markers. So again, and we have a separate protocol. If you have a cone beam in your office, there's a different protocol to use that's involving an alginate tray with fiducial markers on it.
And is the appliance worn on both jaws or just on the relevant jaw?
The appliance is worn just on the jaw where the implants will be placed.
Okay. I think we can proceed.
All right. This is a set of surgical slides on the case that we just did. So, here's the planning, which you've already seen. And this is a ThinLayer case. So this is done differently than a tube case. Conceptually, this is very different than a tube case. And this is something you would use in a situation where you couldn't use the tube because you had inadequate vertical space. So in this case, you use a tube guide with an insert and an endofile or a spear drill to create a bleeding point. That's one point of the trajectory. You remove the tube guide and place a ThinLayer guide. Here's your bleeding point. So the implant trajectory is defined, instead of being defined by the top and the bottom of the tube, the trajectory is defined by the guide tube, the guide hole here, and that's exactly the same position and height as the top of the steel tube or the metal tube that you saw, and this bleeding point here. So now you take a thin spear drill in a drill stop, and you place it through the guide hole, through the bleeding point, right through the gingiva in the bone. That makes a pilot hole in the bone. At this point, you have the option of going flapless or flapping it. I raised a flap here to illustrate how easy it is to raise a flap with this kind of a guide. So here's your pilot hole in the bone. It's only 3 millimeters deep or so, about 1.5 millimeters in diameter. You would then place the ThinLayer guide on. This is a 2 millimeter twist with a drill stop. And this is where you can see it requires no more vertical clearance than freehand drilling. It's as if the guide wasn't there from that point of view. So now you place the 2 millimeter twist at an angle. Again, this person can't open very wide. Tip on the bone. You drag the tip back until it's in the osteotomy, in that pilot hole. You drop the stop into the guide hole, and you drill to depth. This flange determines depth, and the depth was programmed by you when you did your treatment planning. So once you have your 2 millimeter osteotomy, you then repeat the procedure with subsequent twist drills. Tip onto the bone, drag back, drop in, drill to depth. So basically, it's the same as freehand drilling, except you're guided, and I use this in second molar sites. If I can get a handpiece back there without a guide, I can do this in a second molar site. And here you have your osteotomies, full diameter. And what I also would like to show you is we use the ThinLayer guide to center a cortical drill, to center a tap, and certainly to center the implant driver when replacing the implant. And it's so easy. You have full visibility. You can see where you're going. You can adjust the implant depth exactly where you want it. I personally feel that guided surgery has become synonymous with flapless surgery, and I think that's wrong, since I like to flap the majority of my cases. And I have a whole series of technical reasons for wanting to do that. And here's the final implant position. And I put the tube guide on just to show that the ThinLayer guide delivered the desired trajectory pretty much as the tube guide would have delivered. So that's an illustration of the case that we just planned. So far what we've seen is we've seen how one uses articulated models to discern future tooth position. The next case, I'd like to show how we use a temporary bridge to do the same thing. In this case, the patient is wearing a large temporary bridge. And you can change the density of these images. So I'm going to eliminate the bridge. So this is the case. We have a temporary bridge going all the way from 2 to about 13. And there was room for 4 implants. In fact, we placed 3. But to do this case without a wax-up was quite simple. I took an alternate impression of the patient without their bridge, and I took an alternate impression of the patient wearing their bridge. And these data were merged into the planning software. The other question was, how do you merge the data in? The software has the facility to allow merges of different data sets on the basis of fiducial markers or on the basis of anatomy. So that's built into the Blue Sky Plan 3 software. So when I planned this case, I made the bridge slightly translucent. And basically, I just brought the implant into position. I rotated it. I put an abutment on it and rotated it and lined it up with the center of each tooth. And once I had this one in, I duplicated it, and I lined it up with the center of the next tooth. And the same thing going on down the line so that each implant is in the center of the tooth. I had no idea how this would shake out with the bone, but I placed it. First, I shot for ideal position. So that was in the mesial distal dimension. And then buccal lingual, I'm able to see exactly where these are. The center line of the implants are in the center of each bicuspid, incisal edge, incisal edge. So that was the first phase of planning. I'm able to project the outlines of the temporary bridge onto the cross sections. So this is the tooth number 4. This is the second bicuspid. And here we have an outline of the temporary bridge. So now I was able to take the implant. Here's the bone. There was a sinus graft done. And I'm able to line it up in the bone and in the central fossa of that implant. I'm sorry, of that crown, of that temporary crown. And we go to the next, number 5, same thing. A little buckle to the central fossa, but still quite ideal. Go to number 6. We were fortunate the bone was getting thinner here, but still allowed me to line it up with the incisal edge. And finally, number 7, same thing. So in terms of ease, I mean, from where I'm sitting, this is a lot easier than having to set up a large wax-up. And it's extremely accurate, and it's a very streamlined way of getting implants in the correct position in a totally restorative-driven environment. There are tools here whereby you can parallel one implant with another and things like that. And finally, I can superimpose the temporary bridge on top of the patient's anatomy, bony anatomy, and get a look at the relationship between this implant and the adjacent tooth, and this implant and this adjacent tooth, as final confirmation that these implants are in safe positions. So that's one example of using a large temporary bridge as future tooth position.
The question that came in, if you could explain a bit where you put together perch markers on the alginate tray. Do you use a plastic tray and then place them on the tray?
I've got it on the alginate tray?
Yeah.
Oh, okay. Yeah, they're on the back of the alginate tray. The back of the alginate tray, think of it as a horseshoe, and you put 3 on one side, 3 on the other, and 1 in the center. So if you think about it, when you take that impression, so the protocol for if you have a scanner in your office, it's a very, very nice protocol. You make a set of trays like that. You put the alginate tray, you take an impression of your patient. With the impression tray in your patient's mouth, you put them in the scanner and scan them. You then remove the tray, pour the stone model. Do not remove the model from the tray. You now scan the tray in your scanner. So as you can see, that merge will be absolutely perfect. Where the gutta-percha points are entirely in a different plane than any scatter you could possibly have. So you get dead-on merges every time with that system. And again, scatter is a big deal when it comes to merging files if you're doing optical scanning. And by doing these methods, scatter is absolutely irrelevant to our merges, and we have phenomenal confidence in our merges. Again, there are pictures of these of the alginate tray and of the scan appliance on our website. Oh, and we've just sent everyone in the meeting a link to the website, to that particular part of the website that will illustrate those, the scan appliance and the alginate tray. Any other questions, Michael?
No, that's all for now.
Okay. This is a surgery. This is that patient, the one we just planned. This is their surgery, and this was done with a tube guide. Here you can see the ridge that we're using. Here's the tube guide in place. When I raise flaps, I often like to make bleeding points with an endophile. I'm trying to retain attached gingiva, so the bleeding points serve as guidelines for my incision. So I'll make my incisions right through the bleeding points because I know those are the center lines of my implants. So I make my incision. Here you can see our tube guide in place, and you can very easily raise a flap with our tube guide. We do not have a flange covering the site. So we can do tubeless, we can do flapless surgery, or you can elevate a flap. Here's the ridge, and again with the tubes, I just went through with my twist drills, creating osteotomies. Here are the osteotomies, number 4, 6, and 7. Again, I'm using a tube guide to center my driver to place an implant. And here's the final case. Here's the closure. And again, my reason for raising a flap here was I wanted to retain a thick band of attached gingiva on all these teeth. And here's with the bridge in place. You can see the relationships and the radiographs of the implants. So that's an illustration of a case that was done using a temporary bridge as for future tooth position. The next case involves the use of a flipper for future tooth position. And this is an upper anterior case. Okay, so this patient is missing 7 through 10, and the restorative doc indicated that these teeth are in the correct position to represent the future teeth, and so this was done much in which the previous case was done. Implants were placed, centered in each tooth. 7, 8, and 10. The cross-sectional view of the flipper was projected onto the cross-sectional views. Here's number 7. Number 8, nice outline of the incisor. And number 10. So the patient had a reasonably wide ridge. So you can see there was, the challenge on this case actually was to get the implants as buccal as possible. I'll show you that when we look at the ridge. But you can see that in a case like this, it was quite easy, without a wax up, using the flipper as future tooth position. So now we've done that. Again, there's some fine-tuning. I don't mean to let you think that, it's done this quickly. There is a lot of fine-tuning to do when you do this. But these are the basic principles of how we do this in the different dimensions. So again, we can make structures disappear. And now you can see where you are on the ridge. Sometimes when you do this, things will look quite ideal, but you'll find out that buccolingually you're the wrong spot on the ridge and you have to go back and recalculate. But by having this view of the ridge, as you would clinically, you can discern that before you have a guide made. And you can see the relationship between the teeth. You can put the flipper back and see where you are. And also by adjusting the density threshold, you can get a sense of the relationship between the root and this implant, and the number 7 implant and this cuspid. So that's using a flipper for future tooth position. So far we've used articulated models, we've used temporary bridge, we use the flipper, and there's another case here where we use a bridge that had to be cut out because one of the abutments failed. This tooth had a resorptive defect and had to be removed. But before the prosthodontist resected the pontics from this bridge, I snapped an alginate. So I'm superimposing two models here, two models, one with and one without the pontics. So you can see how that simple alginate gives me future tooth position. And again, I can project, as we did before with the temporary bridge, I can project the outline of the pre-existing pontics onto the cross-sectional view. And you can see exactly where you are. And you can adjust as needed. I'm not going to beat you to death with this case, and we'll move on. I'd like to move on now to an edentulous case. This patient had a horrendous ridge, had an ill-fitting denture. Let me just take a look at the ridge. He had an ill-fitting denture that was very unstable because he didn't have much ridge. Here's a pan of the ridge. He had a couple of cuspids that were left in way too long. So basically, planning this case, I found 3 islands of bone that I could use. So I placed implants. I placed this one first, then paralleled off of that one and placed one here and one here. Then I went to my cross-sectional view. Again, on these overdenture cases, as most of you know, it's very important that the implant be centered in the soft tissue ridge. So in this case, we were able to project the cross-sectional view of the soft tissue over the patient's bone. And then place the implant such that the implant is coming through the peak of the soft tissue ridge. This is number 24 site. I think that's the 28 site. Now, the guide that was used, and I don't show this here, we use 3 bone screws to secure this guide. And the bone screw positions are planned exactly the way the same as the implants are planned. So we did put a bone screw right through here, horizontally. We had another bone screw, I think, right about here vertically. And then we had another bone screw horizontally behind this implant. And again, you could see why the bone screws have to be planned, because he did not have much ridge and the mental foramen is there. So if you just placed screws anywhere, you would have a chance of getting in trouble. So bone screw was placed, I think, right through here. And then, of course, you can look at the ridge and ascertain whether or not you are in the peak of the soft tissue. The error that's made in the lower anterior is that oftentimes we have used only the bone scan to place, it's an overdenture, right? So you don't have to know future tooth position. So you get a scan of your patient, and you put the implant in the crest of bone, and supposedly that should be fine, except for the fact that in a number of cases, in the lower anterior especially, the soft tissue ridge is located buccal to the hard tissue ridge. So if you do that, then an error will occur, and that means that the implant will be square in the bone, but will be lingual to the soft tissue ridge, meaning that the denture flange will have to be thickened or a lump placed in order to house the attachment housing. So by being able to visualize the soft tissue outline at the same time that you see the bone outline, obviously is the necessary data in order to plan these cases correctly. I have some surgical slides on that case as well. Okay. This is that patient's ridge. As you can see, it's a severely compromised ridge. In this case, again, I placed the tube guide. I just placed it. I didn't fasten it. And I developed bleeding points because this case was done flapped. Again, you can see there's not a whole lot of attached gingiva on this little tiny ridge. And if I were punching holes here to do a flapless surgery, then I would have removed the attached gingiva. So for that reason, this is surgery. A flap was reflected. But again, I use my bleeding points, and then I use them to guide my incision. So I made an incision, and I reflected the flaps. I then placed my tube guide. And this is the tube. We make a very different kind of tube guide than what you see on the market. This is the tube guide, and it's fastened by 3 bone screws. 1, 2, 3. And when this thing is down, it's solid like a rock. And here you can see I'm fastening a bone screw in this position over here. And once it's down, I drill through the tube guide in the conventional fashion. Now, most of you may know this, but the flaps are closed here. But if you have made an incision and the drill isn't a very, very large diameter, when you drill through the incision, the flap edges will retract and your drill will not cut the flap edges, because I was looking for primary closure. So within limits, it's a very nice technique, so you can flap it first, then bolt the guide down on it, drill through the incision, and you will not tear up the edges of your flap. I prepared the osteotomies initially, and then I placed what we call a ThinLayer guide. This guide doesn't have tubes, but the guide holes up top are exactly the same as the top of the tubes. And the osteotomies are either completely or partially done. In one position, I completed the osteotomy using the ThinLayer guide because I wanted to see exactly where I was. The bone was higher on the lingual than it was on the buccal, and I wanted to determine by vision exactly where I would be. I then used the guide to center my implant driver. Again, the whole buccal of this thing is open. I can reflect these flaps and I can see what I'm doing. And I don't know of any other guide that can be used in this fashion. And we designed it for this particular reason because there are too many cases, even edentulous cases, where a flap is really indicated, and you don't want to be forced into having to do flapless surgery when you know it should be opened. Here are the implant positions. And one other thing we did was that when I planned this implant, the implant's an 11-millimeter implant, and I believe I set the osteotomy depth at 14.5 or 15. And then I placed my 11-millimeter implant because I'm using my implant for depth control for ridge reduction. So once the implant was seated, I knew exactly how far to take this bone down. As you can see, the ridge was reduced to the top of that implant. So that was used as a guide for ridge reduction. And here's the final case, 3 implants in place with primary closure. The other thing I don't like in edentulous cases is having a loose floppy denture banging around on top of the healing abutments. I get concerned about whether that might take out one or more of the implants. So this was primary closure with cover screws. And here's the final case completed. So this patient went from, as you all know who do overdentures, this case went from a floppy denture that was non-functional to where he came in, gained 10 pounds, as happy as could be. The final case I'll show you is using a denture. It's the traditional dual scan method, which we do. If you have a denture that fits nicely, then we can do the dual scan method and make a guide based upon the denture. So in this case, you can see future tooth position is determined by the denture. And we go to our cross-sectional views. When the implants are placed or planned, you can see the denture, and you can see the outline of the denture tooth. Again, this is the traditional dual scan method. So basically, the point I was trying to make this evening is that guided surgery is all about treatment planning. And treatment planning and guided surgery is all about being able to visualize future tooth position. And to do that, you must have the correct data set in your implant planning software to do this correctly. I suspect that a lot of the bad press guides get is related not so much to the fact that the guide couldn't deliver the whole, but the fact that the plan was based on incomplete data. So I hope this helps everybody, and we certainly would like to entertain any of your questions. And I thank you very much for being such a accepting audience.